Perfect. Well, thank you, Susie and Bruce, and that wasn't planned that my first slide has a crystal ball. But as I gaze into the crystal ball, I try to take a patient's perspective, some from what I hear in the clinic and from these conferences for the next future year. Can I switch to a biosimilar? You've heard a lot about this, but I'm going to give a bit of a perspective in terms of my thoughts and questions going forward. Can I stop medications? Probably the second most common question to, is this medicine safe? Which biologic should I take? I'm going to attempt to position biologics in a table format in terms of my opinion. And then what I think we haven't touched on yet, but I'm going to spend the last 5 to 8 minutes of the talk in, I don't have a PCP. Why can't you be my PCP? So new models of care. And then I heard you found a cure for IBD in Pittsburgh. Is that true? That'll be the last. All right, so can I take a biosimilar and is it cheaper? If it is cheaper, is it really the same thing? So you've already seen this. One of the definitions that my patient brought in that I don't think Dave showed in the prior session is the Biosimilars Act. Biosimilars are terms used to describe officially approved subsequent versions of innovative biopharmaceutical products made by a different sponsor following patent and exclusivity expiry on the innovator product. So how much more legal can you get? The FDA definition is that a biologic similar is highly similar to the reference product, and there's no clinically meaningful difference. How have biosimilars performed in IBD? And I think that you saw this nicely in David's talk, and I omitted some of the slides, but just to show one prospective study that was presented at EPCO this year that did show with the infliximab biosimilar a significant decrease in CDAI, CRP, the partial Mayo score. However, there were 4 allergic reactions in patients who had been on a prior anti-TNF. The real question is this: would we even consider biosimilars if it were not for the cost? So in case you can't see this from the back of the room, this is 2011 cost data for adalimumab and for infliximab. And this is 2011, you can extrapolate toward now. So the cost of these agents are obviously big in terms of insurance and health plans, but the cost is a real issue, and I think that Brian and Steve in their talks mentioned this. So the question really will be, as we gaze into the crystal ball of the next year, if the health plan will only approve a biosimilar anti-TNF for your patient, and they quote, and I'm making up this number because we don't know, that the biosimilar is 30% lower cost, what would you do with this patient? 34-year-old severe UC in remission for 2 years on an established anti-TNF and azathioprine, and the recommendation from the health plan is you should switch to a biosimilar. What about this patient, a 27-year-old newly diagnosed severe perianal Crohn's disease with deep ulcers in the colon and ileum, but has never been on treatment? Now, whether we like it or not, and I think Brian said this, biosimilars are here, and they are here to stay. And there are many parts of the world that are already influenced by biosimilars. And I think the questions that we're asking now are going to feel very different in 3 years when they're on the market and we're using these more regularly. So is it okay to start a biosimilar in somebody who's naive to an anti-TNF? My feeling is yes, I think it probably is. Is it okay to switch from an innovator drug to a biosimilar in somebody doing well? And as David alluded to, will pharmacies do this automatically? I have a little bit more concern over that in terms of immunogenicity, but I think the reality is, and I know from a health plan standpoint, this is going to be a question we're asked. Will there be issues with immunogenicity, and really how much cheaper is this, and will the innovator pharmaceuticals decrease cost to realize this? Then the next question, Jean-Fred mentioned this already, is can I stop my medications in IBD, or is this forever? So what we know about stopping anti-TNFs and immunomodulators in IBD, as he showed you, is somewhat limited. However, it's interesting, and I took out again many slides because he showed them, but if you look at this Kaplan-Meier curve, and you were to sit with your patient in the clinic, and you put drug X that they want to stop, probably the Kaplan-Meier curve for recurrence is going to look like this. So the numbers that I remember is that about a year to 2 years after stopping whatever treatment, there's a likelihood of 50% relapse in that patient. And that's pretty much been borne out so far in many of the relapse studies. The story study that he showed you were 115 patients on combination treatment in remission for a year without steroids for at least 6 months. And again, about 50% relapse. There were risk factors that were identified with relapse. And interestingly, 88% re-responded to infliximab. So these are the 1-year Kaplan-Meier curve, 50% story study relapse. He shared with me, and I actually don't think he showed this in his set, is what happens to these patients in the story study now 8 years out. So people wonder, 1 year it's 50%, what happens 8 years out? So what they looked at is 8-year rates of severe relapse. Severe relapse is defined by needing surgery, significant perianal or fistulizing disease. So 81% were without severe relapse. And you may say, well, that's actually pretty good. But then when you look at any relapse, any failure, 15 to 20% without relapse at 8 years. So the rates are essentially 80 to 85% of our patients will relapse over a long period of time. But not all. And I think the question is, there probably are, and in this room, I imagine there are patients who've lost their insurance and have been forced to come off treatment, who a few years later get their insurance back, and you scope them and they're still in remission. There is a percentage of patients that seem to be able to stop. The problem is, we just don't know exactly who that patient population is. The other question is, what's the cost of stopping? Not only the financial, but stopping, restarting, and potential for other complications, other surgeries down the line. So the third question, patients have obviously access to the web and to a large information of data, and they now know that there are several biologics to choose from. How would you position in your practice if these were your patients? So these are 3 patients that I saw within the last year. A 22-year-old severe ulcerative colitic, deep ulcers, failing steroids, admitted to the hospital. And I imagine many of you have a strong preference as to which biologic to use. But what about the 35-year-old female, Crohn's ileocolitis, has a response to budesonide, but now is steroid dependent despite being on azathioprine? Which biologic to use in them? And then Ray and I think Tom also talked about risk. So a 62-year-old hasn't hit 65, but ex-smoker, history of breast cancer, and a squamous cell skin cancer. Which biologic do you position? So these are the biologics that are approved. And I think the way we position them somewhat depends on the label. The problem is, as of today, there's no comparative effective studies that we have to compare agents, and it's hard for us to compare across trials, although we're always guilty of doing this. Demographics certainly play a role: gender, age, weight, pregnancy. Adherence may play a role depending on your decision. Severity of disease, is this a sick inpatient that I presented or somebody that's an outpatient? Subtypes, are they post-op Crohn's? Do they have fistula? What about extraintestinal manifestations? And then, is the ability to measure drug levels going to influence which biologic we use in the future? It's an interesting question. And then finally, safety. We mentioned before, are some safer than others? And do we need to use combination treatment? And then let's not forget costs. So there's not comparative effective studies, but there are also not cost comparison studies in any way that's meaningful for the health plans to say one is preferred over another. So I attempted, and this is my opinion, only my opinion, not evidence-based data, although it's drawn from evidence, on how to position biologics in IBD. So the indication is listed for UC or Crohn's. The biologics are across the left-hand side, the ones that we have currently now. You can't read the top, but this would be severe or extensive disease, so that's severe colitic patient. I think the inpatient that is admitted with severe ulcerative colitis, we are seeing a preferential benefit with infliximab. But the question is, are we not dosing the other agents correctly in that setting, and is it possible if we use a different dose structure that may work? What about safety? I think many people have shown that safety with monotherapy anti-TNF looks pretty good. The question is, do we negate some of the safety, as you've heard in the prior talks, if we add thiopurines? We look at vedolizumab and we get a sense that the gut selectivity with vedolizumab may provide a safer profile, and maybe we're going to use that preferentially. I put over 50 here. I'm not sure why as I am turning 50, but in our over 65-year patients. What about need for concomitant immunomodulators? If your goal is to prevent immunogenicity, and if you are not following drug levels prospectively and adjusting levels based on therapeutic monitoring, I do think that concomitant immunomodulators are required for immunogenicity, at least in the first year or two. So I put this as a yes for any monoclonal antibody. Pregnancy, Uma's already shown you the pregnancy safety data. Now, there are only two agents now, infliximab and adalimumab, in which we can measure therapeutic drug monitoring. And the question in the future is this going to be important, and is there going to be a preference in biologic based on this, or are all of these agents going to ultimately have a TDM? Adherence, 3 are IV, 3 are sub-Q. Some patients prefer coming in to see the nurse and get an IV. Others would like the sub-Q freedom and not have constraints in coming in. And then extraintestinal manifestations, most data in infliximab and in adalimumab. As you know, with vedolizumab, it's a biliary uptake, and there are going to be some trials designed and questions asked about primary sclerosing cholangitis and vedo. So the next question will be, where will we position these? And I think more interesting, will we sequentially use something like anti-TNF for induction and vedolizumab for maintenance? We don't have data. That question comes up. Or will we combine classes, anti-TNF with vedo in the sick patient where we want to use 2 agents aggressively? Again, no data. Tomorrow you're going to hear more about ustekinumab and tofacitinib. Those are the next 2 that I think are probably going to hit the market for us, but those are currently not available. So the next question, why can't you be my PCP? Probably more adequately put, new models of healthcare, especially for chronic diseases. So the 28-year-old with severe Crohn's in remission calls you because they have a sore throat and a fever. And you probably get this in your practice, and they say, I don't have a PCP. Can you treat me? And by the way, can you be my PCP? What about the 32-year-old female who's in an endoscopic remission? She does not have active IBD at this time, but despite that, she's been to the ER 15 times in the last year, and the insurance company, if they haven't called yet, they will start calling you, calls you and says, she identifies you as your PCP, and how are we going to keep her out of the ER, and how are we going to improve the quality of her care? So this is one model, the patient-centered medical home, and I'm going to briefly end with this before how we cured Crohn's. But the one model of care, many of you in this room, and I know this, and I just don't have time to present all of your data, are working on different models of care, and I think we are all looking for that model. The patient-centered medical home that I'm presenting now, I imagine in 3 years will look very different. But the point is, new models are here. We need to start thinking about them, and there will be new models of care tomorrow. So what's the patient-centered medical home? This is derived out of the primary care model of healthcare reform law, by which a principal or a primary care provider takes care of a cohort of population-based patients. They use disease registries, information technology, and overall very much patient-centered, improved communication. We started thinking about this, and for full transparency, part of the reason we did this is we have our own health plan insurance company. So this was a bit easier in Pittsburgh for us to start working with them. But in 2012, we sat down with them and said, you know, probably like many on this panel and many in the room, our centers of excellence kind of is a medical home. We're sort of acting, and many of you act like that already, except we were missing one thing. I think the secret sauce in any chronic care model, any chronic disease model that we were initially missing was mental health specialists. And fortunately for us, Eva Sigathy, who's a psychiatrist who's dedicated her career to this, is in Pittsburgh, and the two of us came together and started collaborating on a medical home, and she really closed that final piece. So our first meeting, if you've not met with an insurance company, this is what they will show you. The first meeting, if you're interested in population-based health around a chronic care model. Probably can't read this, but this is the actual table they showed me. The very first meeting when I was all enthusiastic and coming in saying, we want to do a medical home, they showed me the top 10 costs of my patients. These are PMPM, per member per month cost. Much of this, yes, is driven by treatment, medical treatment. However, the undercurrent that's interesting here is the unplanned medical care that our IBD patients receive. Multiple ER visits, hospitalizations, and readmissions to the hospital that go then with testing, radiology, surgery, complications. And much of that was driven by psychosocial aspects and pain. The other thing they'll show you, and this is the actual bar graphs that they gave me, the top group of patients on the left-hand side with the red arrows, that's the number of patients with IBD by our UPMC health plan. The top number of patients, and then on the right-hand side with stars, drive most of the cost. And this is true of any chronic care model. You go to the insurance plan and you pull up diabetes or whatever the model is, top 15 to 20% account for most of the cost. So we came together and we started enrolling in our medical home in June, and we decided we'd include, obviously, our own health plan insurance patients. They had to have Crohn's or colitis. They were between 16 and 50, and over 25% of the spend had to be primarily an IBD in the past year. So the multivisceral transplant patient where Crohn's is listed as the 5th problem, that's not the medical home patient we were striving for. So how does it work? And I thought about how to put this together, this talk, and I felt I would just be very practical and show you more pictures than words. So we have schedulers now who have completely replaced, and some of them might be in the room right now, who've completely replaced our central scheduling and automated scheduling. They get a real person on the phone, patient-centered. The schedulers ask them not only when they want an appointment, but what are their top 3 concerns and what do they want to get out of their medical home experience. We then meet as a group, psychiatrist, social worker, dietitian, nurse practitioner, coordinator, other physicians, and we huddle before we even meet the patient to strategize that visit in terms of what they want out of the visit. So the patient comes in, we do have them sign a registry consent, so there is a research component, and I've been very transparent with our health plan that we are going to publish off of this, and they fill out some additional questionnaires. Then we have in our rooms, in our digestive disorder clinic, and this is a day when room 18, 19, 20, we ran out of 3 rooms, although usually we run out of now 4 and sometimes 5 rooms. And the psychiatrist goes into one room. That's Eva on the left-hand side. Our dietitian goes into one room. I go into one room. The nurse coordinator serves as air traffic control, and as patients come in and out, we slide our magnet heads into the box of the room so that we keep track of the patients. And the first thing we ask them is, again, what are your top 3 concerns? What do you want to get out of the visit today? Our after visits aren't bringing them in for additional tests and seeing them. We try to keep them out of and into their own environment, home, school, that type of thing. We use a lot of Vigio. Vigio is a HIPAA-compliant Epic platform, telemedicine. Eva Sigathy has been doing this for a long time. Actually, patients will do it off of their palm-held devices now. We now have ER apps. When patients hit the ER, we're dinged with apps. I got 3, unfortunately, 3 of my patients are in the ER, and I know that because an app showed up on my phone. So we're doing a ton of remote monitoring. Telemedicine is key. You can't read this, I don't expect you to, but we put Excel spreadsheets together weekly by which we share information with our health plan. We as a team meet on the patients. We put them into a red zone, danger, going to the ER, yellow zone, and then green zone. So I'm going to end with the first 108 patients enrolled. I'm not going to present too much data except that we've come up with a complexity score which gets into biologic domains, psychiatric domains, social domains, and health system domains. And this tracks very well with healthcare utilization across the top, ER, hospitalization, CT scans, et cetera. So one example I'll leave you with from the medical home is a 44-year-old Crohn's, multiple surgeries, no active disease, but has symptoms of pain, fatigue, and nausea. This is his epic screenshot. 14 times in a 6-week period, he went to the ER. He's been admitted 9 times. He's gotten a DVT, one of the admissions in C. diff, and he has no evidence of active IBD. These are the number of scans he had in a 1-year period. And then we did something when we entered the home, we flipped it. We now see him 2 to 3 times a week. Many of you cringe when you probably hear that. We do a lot of telemedicine. I see him only about 5 to 10 minutes. The social worker and psychiatrist sees him longer. These are our total costs for the patients in the year prior to coming and seeing us. And I think the medical centers that we've said in the past, the centers of excellence where it's revolved around the physician providing care, where RVU generated, is going to probably flip into something different, which is collaborating with our insurance companies, putting the patient at the center of the care model. We then get referrals by the insurance company, and we're looking at payers to help us in shared savings, global payment, and potentially it's going to be capitated care. So I'm going to end with a few slides, a little bit tongue-in-cheek, and then I will sit down. So in 2011, when Steve Hanauer introduced me at the talk, our media is a bit aggressive, I'll say, in Pittsburgh. They said that we cured Crohn's, where really we said we may be able to help patients after surgery. And then regionally, fortunately, this hasn't nationally, I hope it never does, UPMC builds a home for IBD and cures Crohn's. Again, I wish we could cure Crohn's. And what we really said is that a new model of care is needed for these patients. So what would you experience if you come to Pittsburgh? Healthy food, terrible towels and religion, and yes, we're still in the wild card hunt. Yuns and yins are in the dictionary, yins going to AIBD, but sadly not clean air and sadly not a cure for Crohn's. I want to give a shout out to those in orange if they're in the room and not at the bar that are with us today. Thank you very much.